So we want to welcome everyone to our state and local and federal government webinar for today. I want to take a minute to introduce myself. I'm Elizabeth Mumaw, the Chief of the Office of Intergovernmental Affairs here at the Federal Communications Commission. The Office of Intergovernmental Affairs is set up to be the liaison to our state, local, and other federal agencies. So to the extent you ever need us, we wanted you to know, that we are out there. For the purposes of today's webinar, we're going to be have communications go through our live questions at fcc.gov email account. So to the extent you have any questions or you want to provide information to us during the webinar, please use live questions at fcc.gov. So livequestions@fcc.gov. And then for purposes of communication after the webinar, the email address to use would be iga@fcc.gov. IGA is our acronym we use for the Office of Intergovernmental Affairs. To the extent you want to talk to us about partnering on future webinars, or you have other ideas of things that you would like to see on IGA webinars, please let us know. And then I want to let you know who our esteemed colleagues are that are here today that are going to be doing some of the talking. We have Katie Gorsak, Karen Onije, and Dr. Sheikh. They're all here from our Connect to Health Task Force at the Federal Communications Commission. What we're going to do today is go through an overview of what the Connect to Health Task Force is, the basics of the platform demo, and then we're going to take the discussion from theory to practice and show you some user scenarios. We hope at that point to have some time for some questions. And then we're going to talk about how you can integrate your own data into this platform. And then we'll have time for some further question and answers before we wrap up for the day.
Great. Thank you so much, Elizabeth. I'm Katie Gorsak, and I'm the Communications Director for the Task Force. I want to thank all of you for joining us today for this exciting webinar. And our thanks as well to our co-host, the Office of Intergovernmental Affairs. I'd like to start out by providing you with some brief background on the Connect to Health Task Force. The task force was created in 2014 to help strategize across silos in our agency, government, and beyond. Broadband connectivity is transforming the way we all experience health and healthcare in our country. And that there is tremendous opportunity for connectivity to help us meet national health goals, especially for rural and underserved communities, veterans, and people with disabilities. The goal was to make sure that the FCC was thinking ahead, 10 to 15 years ahead, about the intersection of broadband, advanced technology, and health. The task force vision is simple. Everyone connected to the people, services, and information they need to get well and stay healthy. Over the last 18 months, the task force has visited 7 states: Virginia, Mississippi, Florida, Ohio, Michigan, Texas, and West Virginia, and have heard from hundreds of stakeholders as part of this Beyond the Beltway series. In fact, we think some of you might be on the line today as well, so thank you for joining us. And as you'll hear from our colleagues, we've seen firsthand how broadband connectivity can be a force multiplier, how broadband can be a public health tool, how it can drive innovation in health, and help meet the needs of rural and underserved communities. Our demo today will touch on many of the themes that we have heard from our time on the road. Let's dive right in, shall we? Karen and Yahya?
Thanks, Katie. So this is Karen Onije, and I'm really delighted to be presenting today, and just want to thank Elizabeth and IGA again for partnering with us on this webinar. So my job is to do what Elizabeth previewed for you, sort of to give you a basic sort of overview of the Mapping Broadband Health in America platform, or at least as much of that as is possible in the next 10 to 15 minutes. One of the challenges that we face when we try to do this demo is just the press of time, that there is a lot to show you. We think this is one of the most powerful and innovative tools at the intersection of broadband and health. And so really we can only scratch the surface. But I thought it might be helpful, just in case we do run out of time, to sort of skip to the end of the book, so to speak, and give you the key takeaway right up front. And here it is. The Mapping Broadband Health in America platform is more than a map. It really is a new way of analyzing, a new way of thinking about the intersection of broadband and health. And there's a paradigm shift in here as well. You know, we didn't set out, I will tell you, as a Connect to Health task force to build a map. In fact, really the map responds to a lot of the feedback that we got from stakeholders in the broadband health ecosystem. It really is a result of a journey that started about 2 years ago with our very first Beyond the Beltway visit. Yes, we didn't go far beyond the Beltway, to the University of Virginia. And I hope some of those colleagues are on the line as well. And as we went around the country, to Mississippi, to Florida, to Michigan, to Ohio, to Texas, it became clear to us that stakeholders in the broadband health ecosystem didn't always have the data that they needed at their fingertips to drive decisions and drive solutions. You know, public health types had resources on health, and telecom types had resources on connectivity, and sometimes the private sector felt it was caught in the middle, but they didn't all have a shared tool, if you will, to sort of systematically identify gaps and opportunities at the intersection of broadband and health, and to drive solutions and to drive policy. So in building the platform, we wanted to focus on the specific pain points that we were hearing. And I want to give you a few examples of some of what folks have been saying to us over the last couple of years that we think the broadband platform responds to. The first of these is on the screen for you. It's this notion of analytical gaps. And what we heard from stakeholders is that we needed an easy shared way to analyze health in the context of broadband, access and adoption, and to analyze broadband in the context of health. You know, everybody was asking, including us, what does the intersection of connectivity and health really look like? And there wasn't a definitive answer. So that's analytical gaps is the first one. The second is misalignments. So we had folks asking us, is there a way to ensure that investment in infrastructure bills that we all fund and the private sector invests in on the one hand, and then connected health interventions that consumers need on the other hand, could coincide at the same time and in the same place. And they thought if we could do that, if we didn't have misalignment of resources and deployment, then we could create a win-win between private and public sector investment and the market opportunities that are necessary to sustain it. So that was a second theme. The last theme I want to share with you is the notion of sustainability, right? And we heard, what if there was a way to mine the data to identify possible new markets and business models for rural and underserved areas in the broadband health space? And it was really out of this genuine need that the Mapping Broadband Health in America platform was born. It was a need for data-driven decision-making at the intersection of broadband and health. We heard, give us a one-stop shopping approach, but not a one-size-fits-all approach. And so this is the exact opposite of government going in search of a problem. This is a solution responding to an expressed need. So what I want to do is I want to give you a quick orientation then to a couple of key features of the map. And there are just 5 I'm going to flag quickly for you. The first is the ability of the map to facilitate analysis at the macro and micro level. And I'm going to demonstrate these to you. You can see on the screen that, there is a, quote, tab below each of these, and this first one says the broadband tab, so stay tuned. The second feature here that we're going to try to demonstrate in a minute is the ability of the map to characterize the space at the intersection of broadband and health, right? To describe the data and visualize the data. The third feature is the ability of the map to not just overlay two data sets, but really to help us explode and understand the intersection of those two. Fourth, we wanted to do more than just theorize. We wanted to do more than just analyze. We also wanted to drive solutions. And we call that speed to solution, promote cross-sector and federal-state collaboration. So we'll talk about how the map can help with that. And then finally, as Elizabeth mentioned, this platform is certainly open source. You would expect that. It's open data. But it also has a feature that is pretty unique to this platform called open integration that allows stakeholders to customize the platform and to integrate their own data. So I'm going to ask Dr. Sheikh to drive this for me. We're going to go directly to the map because I think a picture is worth 1,000 words. I've been describing it. Let me show it to you and give you a quick peek at some of the things that the tool can do. The first map that we're generating for you is on what we call the Broadband tab. You can see the tabs at the top of the screen there. And to orient you quickly to the way this works is on the Broadband tab, what is being visualized is fixed broadband data. So you're looking at broadband data right now, access data, speed data, or adoption data, depending on what you choose. And then the platform allows you to filter that broadband data by health, by rurality, or both. All right, the second thing you need to know to follow along here is what the colors mean. So what you have are colors that are keyed to different levels of broadband access. We took the broadband data, we divided it up into quintiles, and then we assigned a color to each quintile. So if Dr. Sheikh can point out for me, you'll see that you have 0 to 20% access in yellow. You have 20 to 40 in that mustard, at least it's mustard on our end, color. Then you have 40 to 60% broadband access in moss green, all the way up to that royal blue, which is 80 to 100% broadband access. So if I'm going to oversimplify this just for the purposes of today's demo, I will tell you that yellow corresponds to low broadband access, and that bright royal blue corresponds to higher levels of access. In other words, yellow is bad and blue is good. So with this map that you can see on the screen right now on the left side, you're looking at a national and state picture. And remember I told you yellow is bad and blue is good, so it looks like we're doing pretty well as a nation, right? You can see that most of the states are in that bright royal blue, which we know is 80 to 100% broadband access. There are, about 9 states, including Alaska, that are, one tier down in the 60 to 80% range. But just as all politics is local, so we found is broadband and health. And Dr. Sheikh, if you would just go to the county level so that participants, folks can see, the connectivity picture is much more complex than it appears when you pulled up at that macro level. Immediately you see this sort of diagonal slash of yellow, low broadband access 0 to 20%, going from north to south diagonally and coming around to the Gulf Coast states. But let's overlay some health, right? Because this is about the intersection between broadband and health. So I'm going to, if you would ask the map to filter by diabetes, and what we're asking the map to do is to isolate only the counties with high rates of diabetes, where diabetes prevalence is above the national average. And then we're going to ask, what is the picture of connectivity in those high diabetes areas. And, you know, when we were asking ourselves that question, there was no tool to immediately visualize it, as Dr. Sheikh has done for you here. And, you know, and so you can look at this picture and you see all of those areas of yellow where the connectivity resources are very low, but the chronic disease burden is extremely high. This demonstrates the power of the platform to facilitate, again, that macro, micro level analysis. We're going to quickly move to the Health tab, and I want to demonstrate a second key feature here with this. It's the platform's ability to characterize, again, the space at the intersection of broadband. So now I'm going to need some imagination from folks. So I want you to imagine, and it may not be hard for some of you, that you are a policymaker. So you're local, state, or federal, and you want to know, you have a question. What is the picture of obesity, right? A scourge in our country. What is the picture of obesity in high connectivity areas? Areas where broadband is very good, broadband access is very good. What is the picture of obesity in those areas? And Dr. Sheikh is creating that picture for us on the Health tab. And as he's doing that, remember, in contrast to the Broadband tab, this tab visualizes health data and allows you to filter by broadband. So in this case, yellow corresponds to lower levels of whatever the health metric is that you chose. Yes, in this case, we chose obesity. And red corresponds to very high levels of obesity. And unsurprisingly, you know, you're going to see that there are, you know, large swaths of red across the country. What Dr. Sheikh has done is to isolate those areas where broadband access is greater than 80%, where broadband access is good, and you have immediate clarity then about counties where connected health solutions around weight loss and weight management might be most valuable and effective and could be deployed today. So this map is not only about showing gaps in terms of resources and needs, but also opportunities that can be leveraged immediately. I'm going to quickly move to the Overview tab to demonstrate the ability of the map to conduct sort of multi-factor analysis, right? Things you would not be able to hold in your head, so to speak, and again, to accelerate solutions. So shake off the trappings then of the policymaker from the last example, and imagine now that you're a health tech entrepreneur or you're being approached by an entrepreneur that wants to enter the market. And the startup here has a product that leverages broadband to reduce another chronic disease problem in this country, diabetes. And you want to, and you and the startup want to identify clusters of counties that are ripe for deployment of this application or intervention. And it's really important to the business plan or to the county's strategic plan or the county health department's plan that at least 60% of the residents are using the internet at home. So where do you start? And so the map that's being developed on the screen live for you is showing the counties that meet the connectivity metric that we've chosen, which is internet adoption at 60% or below. And those counties are being shown in blue. And then we're going to leave diabetes as our health parameter, and we've chosen diabetes above the national average, and those counties that meet that filter are shown in pink. And here is the kicker, right? The counties where both parameters apply, the intersection of broadband and health, those are in purple. And those we call the double burden counties, right? And you can understand why we would. There's a burden of high health need and relatively low connectivity. And what's interesting about this data visualization is it tells us things we didn't know before or things that we might suspect but couldn't prove. That these areas cluster together, and that clustering can actually drive solutions. Again, back to that term, speed to solution. So one of the key findings that became clear after we visualized the data in this way is that the majority of these double burden areas, high chronic disease, lower broadband access, fall into clusters of at least 5 counties with total populations of over 100,000. And we know that this has significant implications for crafting successful and sustainable business models for health and connected health in rural areas. All right, so we've zipped through a few features of the map, and I just want to flag one thing before we sort of head off toward Q&A here. So we've been talking about data visualization, but we actually wanted to take it one step further. We wanted to figure out, okay, so we know where the gaps and opportunities are. Could we identify the 100 counties with the greatest need at the intersection of broadband and health? And so we did that data analysis, right, of the data behind the map, and we created 2 critical need lists. One we call the Priority 100, and the second we call our Rural 100. And these lists offer a roadmap for collaboration, a roadmap for private investment, philanthropy, coordinated public support, along the federal, state, and local continuum. And I want to show you where to find this because we're hoping that this will really spark your interest. So, we put right up front for you the page for the Mapping Broadband Health in America platform. It's fcc.gov/health/maps. And in order to get to the Priority 100 and Rural 100, you navigate to it on the left navigation bar there. You see Priority and Rural 100. Dr. Sheikh is pointing to it. And then you click on the hyperlink for Rural 100 in the first paragraph as Dr. Sheikh is doing. And here you go. This is our Rural 100, and you're going to see Alabama here at the top. Let me quickly emphasize for you that these are not ranked in order of importance. They are actually organized by state alphabetically and then by county alphabetically within a state. I also want to flag for you that these aren't all the areas in the country that have connectivity needs and health needs. We did apply some filtering and inclusion criteria to identify a set of 100 counties, a place to start, if you will, where working together we could get the biggest bang for the buck, so to speak. So I wanted to just flag for you a couple of things about this list very quickly. State and county is self-explanatory. You'll see that we have a rural broadband access percentage. And on the Rural 100, we're looking at the portions of the counties that are rural, and we're saying, what is their broadband access percentage? And you'll see that nationally, on average, it's about 61%. You had to be below 50 to make this list, and there are certainly counties here in the single digits. And then we looked at internet adoption. We looked at chronic disease, diabetes, and obesity. We looked at quality of care, preventable hospitalizations. But the column I want to take 30 seconds on is the more data column, because we know that there are real people and real stories behind all of these numbers. And so we wanted to create a data key for you, which is at the bottom of each of these lists, so that you could get a flavor for what is happening in these counties that are the critical need counties. And so you're going to see all these abbreviations. So let me pick on V, for instance. There are a lot of V's. And V just tells you that veterans are overrepresented in this Rural 100 list, or you'll see 65 plus. It means older Americans are overrepresented. You may also see PCPS, which is just short for Primary Care Physician Shortage Area. These are areas designated by HHS as not having enough primary care docs. So I will tell you that we view this as a call to action. And we are hoping that stakeholders like all of you in the broadband health ecosystem would be willing to partner with the FCC and with others to sort of leverage broadband for health in these areas. For those who are more visual people, I wanted to quickly show you how this looks on a map. This is a visualization of the Priority 100 and the Rural 100. And what you see here is that they cluster together, and that has implications for how we solve some of the issues here. You also see there's some overlap between the two lists. I think I should pause there, and what we should do, if that's okay, is to think about this as a sort of a 101 class. There's much more to learn. We're happy to answer questions. Before we take a break for that, though, I think it would be useful to shift, if you will, just from the theory that we've been talking about, and just give a couple of examples about how local and state participants in the broadband health ecosystem, like all of you, could actually leverage the platform to solve problems in the real world. And Dr. Sheikh, do you mind taking that on? So we're moving from theory to practice.
Thank you so much, Karen. This platform actually offers a very powerful set of tools to folks who want to use it at the county level. So we'll start with the county level use case. Imagine we are a county health department, and imagine we are a county health department that has a high level of health need, low level of physical resources. Perhaps there aren't very many physicians in our area, and our broadband access levels are perhaps very low. Well, in that case, if we are that county department, one of the things that we'd want to do is identify who else is around us in our vicinity who might have similar challenges, similar restricted resources that we can coordinate and collaborate with to overcome common challenges and achieve common goals. Well, in order to do that, Karen has shown previously that you can use this overview tab in order to identify regions of clustering, counties that cluster together in 5 or more groups. So in order to do that, what you do is you select a broadband parameter. In this case, we chose broadband access. We set it to 0 to 50%. Less than 50%, we're considering low in order for the sake of this visualization. We selected counties that are above 10% diabetes. So we're looking at all the counties that have diabetes greater than 10%, and those are all represented in pink. Those counties that meet the parameter of low broadband are represented in blue. And those counties that meet both, having low broadband and high burden of health of diabetes, are represented in purple. So as we saw earlier, we see a lot of clustering. Now, if we are a county, though, and we want to be able to understand who else is, which cluster do we belong to, or in other words, what is our neighborhood? Our neighborhood being this thread that weaves us together with other communities that also have common challenges and common goals. Well, how do we do that? Well, in order to do that, what we can do is we can select a particular county. So let's, for the sake of this demonstration, let's select Mingo County in West Virginia. So this is West Virginia right here, and Mingo County is right here. And let's look at some of their stats, and then we can work out how to identify what the neighborhood is around Mingo County. So let's look at the broadband metrics. So Mingo County has broadband levels at fixed broadband levels at 26%. We will look at the rural broadband access in just a second. In terms of health, we'll look at diabetes because we were just looking at that example. Diabetes is at 13%. Mm-hmm. Nationally, the diabetes is usually at 10%. So there's much higher than national levels for diabetes. Look at the demographics. Majority of the population in Mingo County, 23,000 people, are rural. The total population is 26,000, and we see about 90% is rural. So we can consider this a rural county. Majority of the population lives in rural areas. A high burden of health needs, low broadband access levels. So which neighborhood do we belong to? Where does our neighborhood start? Where does it end? In order to do that, what we do is, first of all, let's select for all counties that are rural, and let's visualize that first. So that's greater than 50% rural population. So that still leaves us with quite a few counties that are surrounding us. So then what we do next is we identify our rural access level. Our broadband access was 25.6%. So we identify a metric. So we can identify the broadband access metric, and we select a window within which our access level appears. So we will select a window 0 to 50%. Our broadband access level is 26%, so we fall within that window, so we're going to be highlighted. But then we all of a sudden see that there's a group of counties that are also highlighted. The ones that are in blue end up within this window as well. And let's select on diabetes again. And we chose diabetes greater than 10% because our diabetes rate was 13%, and we wanted to select a window that includes our rate and also see all the other communities that have similar burden of health need. And we all of a sudden see that Mingo County is not alone in its burden of health needs and low resources. We see that it's surrounded by a number of other counties. In fact, what we see is something really interesting. Let's zoom in on this. We see that Mingo County in West Virginia, West Virginia, belongs to a group of counties that transcends state boundaries. So we have West Virginia here, we have Kentucky here, we have Tennessee down here, and Mingo County belongs to a cluster, belongs to a neighborhood that transcends that. So the topology of needs and goals transcends the geography of political boundaries. Not only this, not only can we identify counties that we can work with and collaborate with in order to meet common health risks that cross boundaries this way, maybe not this way, so this would be the counties that we'd want to work with for this particular, in this particular instance. But the other thing that this shows us, another use case, is that it allows us as a county health department or other county entity to offer a value proposition. We offer a value proposition to investors, to entrepreneurs, in order to show them that there's a great level of need in health that can be met through connected resources. So what we show is that in this county where broadband access is low, we can partner. One of the collaborators we want to have around the table are providers. But then we see that once the providers are there, there's actually a sustainability model that can be developed around the high health need. In this county, in this cluster of county, Mingo County itself had 25,000 people, but this cluster of county has about 350,000 people. And the number of people that have diabetes here and obesity is about 50,000 and 130,000. Compare that to other places where, for example, San Francisco County has about 900,000 people for the same level of disease burden. So what we are seeing is that the value proposition that this can actually offer to entrepreneurs and investors around engaging in connected health solutions is actually very great. So this is two use cases that we looked at around using our platform to actualize partnerships, collaborations, physical, and also attract investment.
Well, at this time, we'd like to take a quick break for questions on what we've seen so far. As a reminder, you can email questions to livequestions@fcc.gov. That's livequestions@fcc.gov. We will also allow some time for questions at the end of the webinar as well. But again, please email your questions to livequestions@fcc.gov.
While we're waiting for some questions to come in, can you talk a little bit about why the data is at the county level as opposed to a city or a census block?
It's a really good question. And, we struggled with this a fair amount because there would certainly be value in getting even more granular. But here's why we made the, architecture choice that we did. One, we wanted to make sure that there would be apples to apples comparisons, not apples to oranges comparisons. And we wanted to find a data set on the health side and on the connectivity side that would be common, right, to all counties. And unfortunately, there is not one common data set across every census block or neighborhood, right, so that you wouldn't have the apples to apples comparison. So that's the first thing. The second thing is probably equally important, and Dr. Sheikh, who is sort of the chief architect of this map, I think can talk to this more if folks are interested. I talked earlier at the outset about the importance from our perspective of not just analyzing, but actually building a platform that would drive to solutions. And so we thought of counties as discrete geographical units that could potentially drive economies around broadband and local health needs and policy, right? They're neither too broad, such as a state level. Remember, we saw such variability when you looked at state versus county, nor too granular, such as a neighborhood, where you might not be able to build a sustainable business model around a particular neighborhood, at least my neighborhood, which is very sparsely populated. So, and then third, we will tell you that counties are sort of common building blocks for publishing many types of data and for tracking progress both regionally in terms of population and economics. And so it seemed like there was a tried and true path here. And that is, those are the key reasons why we architected it that way.
Can you also talk a little bit about, for folks who don't know, how the FCC defines broadband and how you're defining broadband for purposes of this discussion?
Sure.
And that actually was a question we got from one of our audience members.
Perfect. So for the purposes of this platform, which is looking at the intersection of broadband and health, we wanted to certainly be aligned with the Commission's definition of broadband, its most recent definition. But we also wanted to make sure that we were using a speed threshold that was sort of commensurate with the kind of connected health solutions that we already see being deployed in the market, many of which are very forward-looking and require, significant bandwidth. So what you have in the platform is access being correlated to the benchmark speed of 25 megabits per second download and 3 megabits per second upload. For internet adoption, we are looking at subscribership data. So I was first talking about access data, but we also have adoption data, and we're using subscribership data there. And I want to clarify something for the person who asked. When you're looking at internet adoption data in this map, we're not talking about broadband. We're in that instance. We're talking about adoption of any level of internet connectivity to the home, starting at 200 kilobits per second, sort of snail mail email speeds, all the way up to broadband. One thing I'd like to flag for folks as they're thinking and digesting the map is, when you generate a map with this platform, the platform actually creates a unique URL for the map that you have generated, the map you've customized. And in order to share that map, whether it's with someone in the office next to you, or across town, or a colleague in an academic institution across the country, all you need to do is to actually copy that URL, paste it into an email or a text, and when they get that and click on it, they can see exactly what you customized on the platform.
We're getting a few questions in here, and I'm just going to pose one question that we got from Steve Hirsch at HRSA. He's asking about the percentage of the population that is listed as rural to designate rurality of the county. Is this using the Census Bureau's urban population versus rural population to designate counties as rural?
Steve, thanks so much for the question. That's a really good question. The issue of rurality, as folks know who are in the field, it's actually very complicated. So there's some definition. There are a number of definitions across agencies, the number of definitions within agencies, and depending on the discipline that for which you want to be able to use that definition, it changes. For example, the definition that the CDC might use in order to understand the health needs of the population is going to be different than that used for understanding the economic needs of the population. Keeping in mind, being cognizant of this variety of definitions, what we did was, instead of selecting perhaps the OMB definition or one of the other ones, what we did was two things. One thing is we looked at the census block level designation of rurality by census, and the proportion of the population that lives within a county in rural designated census blocks are considered the proportion of the population of that county that is rural. But that's just for the sake of representation, recognizing that there's a multiplicity of definitions. So to capture the multiplicity of definitions, though, we do have underlying the data set. When somebody downloads the data, there are actually a number of rural definitions that are actually included in that data set, in addition to the one that we have included. So there's certainly a percentage, but then there's also the OMB definition, there's the USDA definition, and a number of other definitions as well. And in addition to that, we do have, when we get to the open integration files, we'll talk about this, but there's a way to expose that so that you can actually, instead of filtering by the rural definitions based on percentage, we can actually do it according to the one of the other definitions that may be more aligned with the particular question you have, want the map to answer.
Okay, thank you so much for these questions. We keep getting a lot of questions in, which is really exciting, but we want to make sure that we get to some of the additional portions of the presentation first. So now we'd like to move on to a discussion regarding the open data and open integration model that allows users to bring their own data to the platform. Dr. Sheikh will be leading us in this part of the demonstration. Thank you, Dr. Sheikh.
Well, thanks so much, Katie. One of the things we want to mention is, as Karen pointed out, we are very much focused on driving solutions. And one of the ways that we want to drive solutions is to engage in the open model that has developed around IT and technology. So we are aware of open source, where we make the source code available to the public, where they can modify it, etc. So we've certainly done that. And we're also aware of the open data model, where we make our data available. And we can actually do that through going to our map, and at the very bottom of the tabs, you can see that there's a data download button, and you can select to either download the entirety of the data set or a particular subset of the data. And then what we have done, though, is done a new paradigm called open integration. Now, the idea behind open integration is really to increase and augment local capacity. So instead of providing access to data from our servers into their environment, what we want to be able to do is, in addition to the data, allow the power of the platform to be deployed in the local environment. And the reason for that is there might be data sets that individual entities might have available to them that are not available on our servers. Or they may have data sets that are available to them that they may not want to share across the internet. In that case, they can't really send the data set to us, and they can't certainly put it on the internet and integrate it somehow into our platform. But what we can do is take our platform to you. So an individual can actually go to a site and download the entirety of the platform. Once you've downloaded the platform, you can integrate proprietary data sets, and you can do this in 3 easy steps in a few minutes, without actually knowing coding at all. This is actually all HTML, so it's pretty straightforward. So let me show you how that's done. Once you get to our broadband mapping landing page, there's going to be under the data tab, there's going to be a link to our GitHub site. And this is the GitHub site that you would go to, is the open integration site. And there are things called extensibility files that you download. And once you download this, you can actually deploy it on your local environment. There are 3 easy steps. Step 1 is download the file. Step 2 is save your data correctly. And then step 3 is actually do the integration. And they're worked out examples. And in addition to the worked out examples, there are actual examples you can download. So we have 2 examples. There's a disability population files and there's veteran populations files. So for the sake of for this webinar, we're going to look at the veterans population files. So to make a note, the veterans population files are not on our server, and as you can see here, note that we have one filter, which is a rural filter, and note the URL, which is fcc.gov. This is on our website. But now what I've done is I have actually, before the webinar started, I downloaded the extensibility files onto a laptop, and you can see that I'm running this off my laptop here from the F drive, and all of a sudden you see that there's a tab here. And what this tab is doing, this new drop-down menu is doing, is it's a interface to a data set that I have on my laptop about the veterans populations and how that distributes across the U.S. This is really useful because The ability to look at health needs and then whether infrastructure exists to meet those needs becomes really important when we want to look at how other populations distribute across that. For example, how do elderly populations distribute across health needs and infrastructure? What about disabled populations, or in this case, what about the veterans population? So with once we have integrated that, you can make a selection. In this case, we want to be able to visualize all areas that have low broadband access, high burden of health need, and in this case, veterans population that is greater than 10% in the county. So what we're looking at here are all the counties where the veteran population is greater than 10%, and recall blue being the areas where broadband is the metric that we selected, in this case less than 50%, and pink are all the areas where, all the counties where the health metric diabetes is greater than 10%, and purple is where the low needs and high resources coincide, and in this case in all the areas that have high veterans populations. So this is one example of how you can use the files and the examples to integrate your own data sets and not only use the power of open data and open source, but also open integration to analyze data sets that are of interest to you to investigate questions that matter to local communities.
And one thing that we'll try to do is to actually pull up for the gentleman who asked the question about rurality. Let's see if we can pull up, while we're taking other questions, the files that show the different rural definitions. So we'll see what we can do on that. We like to keep ourselves on our toes here. And there was just one other thought I wanted to get out there, if that's okay. Interestingly enough, one issue that Dr. Sheikh is pointing to is a tension between keeping a platform like this, which is cross-sector, relatively simple and easy to use, right? So not just for data scientists and researchers and academicians, but also for, people who may be sitting in a chamber of commerce or maybe in a state house or at a state PUC who may not have sophisticated, analytics expertise. And so the data integration, the data open integration model was really to facilitate having a relatively streamlined and simple platform that could be extended and scaled up. So for example, we have some colleagues who are very concerned about opioid addiction. And so they have been able to take our platform, which does not include opioid addiction data, and to layer that on for their particular locality or community. We have some other colleagues who are interested in cancer, and they've been able to take data around cancer, not only prevalence, but lots of other aspects of that data. And then there's a third group who Dr. Sheikh sort of pointed to about the ability to think about how different data sets intersect. And so it's not only on the health side, there may be data that has PII in it that a health system or some other state or local entity basically would not be able to share outside of the closed system that they have unless there's some HIPAA exception. And so here we wanted, this is a key part of the architecture that would allow you to retain those privacy protections, but still leverage the power in the platform.
Okay, well, thank you so much, Karen. And as Karen was speaking, what I was doing is downloading the data set. And what we have here is a data set that looks at the various variables that you can download. Actually, I think I downloaded the wrong one, but as Karen pointed out, what you can do is not only download these data sets, but integrate them into your local environment and integrate your data sets into this environment. So let me just figure out where this particular
So are there any other questions that folks would like to offer? If not, we're happy to keep going, but I think one of the benefits of the webinar is sort of issues that come up live with the particular participant, so we definitely want to preserve that opportunity.
Okay. I do want to point out, so this what I have highlighted here, as you can see, is a number of rurality metrics. So there's a number of rural definitions, as we know. There's one definition related to our internal use, the USAC from the FCC, and not only does this definition have the USAC categorization, but then the specific census block levels under which that designation is categorized. We also have the OMB definition of rurality in the data. We have the NCHS one that the CDC uses to categorize health. We also have the USDA rural definitions within the data set. In addition, there's some other data that we've included within the data set, which you can see on download. So this is the census designation of persistent poverty for a county, and there's some really interesting analysis that can be done around that and whether broadband is available and adoption is available or not. And this is all in addition to the census percentage that we have seen as part of the rural designation. I'm sorry, it looks a little bit messy, but then it's because I think I converted from a text file to a CSV file. But then once you download it to your own laptop, it should be much easier. But this is by way of indicating the multiple definitions that we have available.
A reminder again, if you do have questions, and we have some coming through that we're taking a look at, live questions at fcc.gov. We will be wrapping up here shortly, but if you do have questions, and I also just want to flag, if we don't get to all questions today, we will get to your questions after the webinar has concluded. Sometimes there's a lot of things that we can provide you that we can't necessarily even provide by talking, whether they're files that will be helpful to answer your questions. So we want to be able to give you all opportunity to ask as many questions. If you have questions actually after the webinar has concluded, if you think, oh, I would have loved to have asked this, please send us an email, and we'll provide those emails at the end of our webinar so that you can send your questions at a later time.
So I think there's a question about the nature of the broadband data and from a gentleman in California, and I think what we'll do is to make available to the webinar participants a link to where all of this broadband data resides on the FCC website. So the Connect to Health Task Force is using the broadband availability and access data that the Commission collects as part of its 471 program. And I think what we'll do is we'll just make that available to everyone so that if they want to learn more or dig into it, they can.
We actually did just get another really good question. So how frequently will you be updating your data? And this is coming from our friends down at University of Virginia.
Fantastic. So we are actually working to do another update of this map. So the map is about 3 months old, but if you snooze, you lose. And we're working to add into this platform not only the next cycle of broadband data, which was just released, but also mobile data, which the Commission just released as well. So the plan is to update the platform periodically as additional data sets become available. There are also some additional health data sets that have become available, and we're working to integrate those into the map. The plan is to not remove the current data set, right? Because there could be value in being able to compare one data visualization with one data set against another data visualization with, new or updated data. And so to allow us maybe to track some progress over time, the current plan is to have both exist side by side or coexist somewhere in the platform. That's a great question. One thing I would tack on here is, feedback is very important. And we would urge you by emailing engagec2h@fcc.gov. There have been lots of questions about data. And it strikes me that that's important. And I would urge, the folks on the webinar here to say, look, are there other data sets that would be helpful? Or are there other ways of slicing and dicing the data that you think would be valuable to the stakeholder community in the broadband health space?
Yeah, and just another tack onto that. So in the update, the other thing we're going to be able to do is actually get deeper into the analysis, but make it actually simpler. So the analytic insights might be more powerful, but getting there might actually be simpler. So what we want to be able to do is have variables in there that might actually be halfway analysis. So the insights that people might get from this might actually be very useful. So to stay tuned for that as well.
Thank you so much, Dr. Sheikh. And so I want to thank you all again on the phone for joining us today. Mapping Broadband Health in America is available online through the Connect to Health website, which is fcc.gov/health/map. And in addition to having the direct link to the map itself, there are a lot of other online resources, including PowerPoint tutorials that dive in a little bit more into the specifics of all the various functionalities of the tool, as well as additional user scenarios, some sample maps, and some key findings. The C2H Task Force plans to host additional webinars in early 2017, including one that will focus on what the data tells us about sustainable business models for rural and underserved areas. We'll be providing additional information on our website in early January regarding those upcoming webinars. And as Karen mentioned, we'd really love to hear from you. First of all, we'd love to have any feedback you might have on today's webinar. We'll actually be sending you an email shortly after we conclude today to do just that, to let us know what you thought. And as Karen mentioned, how you're using the tool and what insights you've gleaned from the platform, as well as any suggestions you might have for additional data sets or interest groups that might be interested in the webinar. And Elizabeth, do you have anything else to add?
Yeah, I just want to reiterate the thanks to the Connect to Health Task Force for partnering with us to bring this to our state and local government partners. And I also want to remind folks that to the extent that you have questions after this event, feel free to get in touch with the Office of Intergovernmental Affairs using the email iga@fcc.gov. And we also will be planning some other webinars for our state and local and federal partners. And to the extent there is something specific you'd like to hear from us, we'd like to know that so that we're giving you the right content. So please feel free to use that web account, give us a call, whatever works for you. I think that's it. I think we're finished for today. Thanks everyone for joining us.
Right, thank you all so much for joining us today. And again, send any questions you might have to the emails you provided. And thank you so much for joining us.